how can we improve our understanding of wheezing, and how can we overcome the disagreement between the families and the physicians. So we will be talking about the struggle of pediatricians and parents with a wheezing child. So the first questions are easy. Are all reported wheezing truly described by parents? Of course, no. And the second question is for us, for the pediatric pulmonologists and pediatricians, is all that wheezes asthma? Again, no. So there are two different sides of difficult and different sides of this question. So why is it important to recognize wheezing? Because if we are talking about wheezing, then we should know the benefits of the definition and treatment and prevention of wheeze. So first of all, emergency room visits. Now summer is ending and now the season is starting. In autumn and winter, our emergency rooms will be full with wheezy child with bronchiolitis and asthma or wheezy infant, however you call. And the second important question is for diagnosing asthma. Unfortunately, we don't have any gold standard to diagnose asthma. Wheezing is the most important tool for us, and we are in the same position with Hippocrates from the country of Costas and mine as well, maybe. And the third one is, in order to get appropriate medical treatment, you should diagnose wheezing. Otherwise, if you don't, especially in the developing world, if you don't call the disease as asthma, you will not be giving inhaled steroids or leukotriene antagonists to treat and to control asthma. So because of these, detecting wheezing is very important. And another practical aspect is frequently usage of antibiotics in these kids. Most of the kids in the emergency rooms are receiving antibiotics due to some terminology called as bronchitis, or I'm not sure whether it is pneumonia or not, that let's give antibiotic. If you cannot call the lung sound as wheeze, it is a problematic one, and most of these kids are receiving antibiotic. And again, another aspect is unnecessary lab tests. Normally, in most of the cases, you don't need any lab. You don't need to draw any blood from the kid, or you don't need to get X-ray. But if you cannot call this patient is wheezing, then this is a big problem again. And now the personalized medicine is fashionable, and in the future, I think we will be dealing with these issues much more often. So we should decrease the anxiety levels of children and the parents. So it should be a patient-focused approach. And if you can say it is wheezing, then you can assure the patients and parents that their disease is not a severe one. So this is a nice study performed in UK, and just to show the other side of wheezing, how the patients or parents feel at home, for example. The red ones, I can understand it's difficult to read, but the red ones are the fear and anger of the families. The green ones are joy and happy memories. So when they are at home, you can see there is no happy moment because there is uncertainty. Is it wheeze? Is there any severe disease? Shall I take my child to the emergency room or so on? But even in the emergency room, pediatric board, special clinics, you can see that if the diagnosis is not clear, if the physician cannot say it is wheezing, then this fear and anger is continuing. This is an old study 20 years ago, one of the first studies showing the disagreement between the physicians and patients or parents. Because as physicians, we always think that we know everything. We diagnose. Even sometimes some physicians I know get angry about the patient. Oh, I'm the doctor, I will know this. This is totally wrong. This is a proof for that. You can see here, in only 45% of the cases, parents and doctors were in agreement. So more than half parents and doctors think the other way. So in 39% of the patients you can see here, doctors found wheezing, but the parents were not calling it as wheezing. So especially when you think about the terminology used by physicians in the ERS task force organized by Kostas, even the doctors do not know how to label it. But from the parental side or patient side, it's terrible. In Turkey, still, I cannot be sure what they are calling. Just I'm trying to mimic, asking them to mimic the sound, but it's not so accurate as you can imagine. And in 14%, you can see here, parents say there is wheeze, but the doctors say no. So it's problematic. And if you can see, look at the left-hand side to the responses to the open questions, you can see here, especially in the sound, they call it hissing, squeaking, whistle, rasp, what I hear. It's so complicated. There's another old study, but nice, because when you look at the severity of the wheezing, we can see here, if the wheezing is easily heard, the agreement is high, near 94% of the patients. If the wheezing is heard easily, also doctor found it easily. But if there is barely, you can see here, this agreement is going up. And the interesting point is the figure 2. When you look at the lung functions, peak expiratory flow rates, if you hear the wheezing easily, peak expiratory flow rate is something around 55%. If there is none, it is above 90%. So if the parents are hearing wheezing at home easily, you can just ask them directly rush into the emergency room, because maybe there will be a problem, risk for hypoxia or so on. So again, in terms of the parental understanding, ethnicity is important. This is a study, again, performed in UK among more than 4,000 patients. If the patients are South Asian, they are under-reporting wheezing. If your language is not English, again, you're under-reporting it. Again, if the mother is not giving the history, if you are not asking to the mother, again, the response is less accurate than expected. So in most of the studies, mothers are used. So maybe when you are reading a paper about that, you should be looking at whether mothers responded it or the others. So again, socioeconomic condition affects this, mother's education affects this. If the mother is well educated, they can have more agreement with physicians than the others. If the mother had asthma, if the patient had recurrent wheezing, the agreement increases. So it is a benefit for the history taker to ask these and then to evaluate these to be much more accurate about the wheezing. This is another study about showing the other way. Again, the agreement is 73%, but this time parents and physician interview wheezing and shortness of breath with parents were 20%, but the doctors found it 36%. So it's in the other direction. So according to the populations you are studying, it can differ. They can be under-reporting or over-reporting. Of course, the age of the children is important. If the parents are talking about a child at 3 years of age, the agreement between the physician and the parents are 80%. But if the child is 11 years of age, it goes up to 92%. So if the child is getting elder, then the chance of being agree with the parents are getting higher. So you can see here again, and the risk of asthma also prevalence is going down with the age as expected. The first episode of wheezing is always tricky. Here you can see if the patient has fever, the patient can be reported false. The parents can report false. But if there is tachypnea, accompanying tachypnea, you can trust on the parents much more reliably. Again, it's same for the bronchi and so on. But in the end, again, parents know it best. If they report true wheeze, true positive wheeze, you can see here asthma prevalence is nearly 20%, but if there is false positive, it is 4%. So if there is an agreement between the physician and the parents, you can say that the risk of asthma is much more higher than the normal population. And again, lung functions will be lower in these correct recall group. It's even lower than the wheezing group. Only if the only doctor hear the wheezing, it is even higher than the both-sided agreed patients. Identifying wheezing is challenging for parents, and children may not be able to, of course, we don't expect them to articulate their breathing trouble. And also there is not, experienced physicians will be agree with me, there is not only one kind of wheeze. There are different types of wheezing, even you cannot just label them. And all this noisy breathing coming from blocked nose or congestion, or even from a throat infection can be a confusing factor, especially, for example, personally, I'm asking them, make their child to cough or just make laugh. Then if the sound disappears, it means that it's not wheezing. So what about physicians? The second part, Kostas mentioned about these and all these tables and these frequencies. Is it wheeze or rattle? What are the additional findings? Is it localized? We should be careful about foreign body aspiration. There are so many children diagnosed as asthma, but have foreign body aspiration, especially in the Mediterranean countries. And what about the risk of bronchiectasis? We should be careful about this. So the difficult side for the physicians, there are two parts. One is it really wheezing? Is there any other disease, underlying disease with this kid wheezing? So, for example, in acute bronchiolitis, it is maybe much more common than asthma. We will be hearing polyphonic wheeze and inspiratory crackles. And in acute bronchitis, due to the excessive secretions, it can be rattle. Rattle can be heard. And the same doctors can be calling these as wheezing. So it's really a difficult task. Maybe we will be needing artificial intelligence, which will be mentioned by Professor Van Alderen. Acute viral bronchiolitis is another disease that we are depending on wheezing. It is the much more accurate definition factor. If you hear wheezing on auscultation, you can call it as bronchiolitis if you are really thinking about bronchiolitis. Even there are some studies showing, is there any way to distinguish different viral infections? For example, at the A column, you are seeing influenza, and B, it's RSV. So you can see here, if you hear wheezing, the risk of this child having RSV is higher, but in influenza, there is no high risk when you look at these studies. Again, how do you call asthma when you ask the doctors? Again, wheezing is a 7 times higher risk for asthma diagnosis. Of course, when you see the patient, it is important. If you hear wheezing at rest or nocturnal cough, it differs. For example, wheezing at rest is the much more accurate one, as we expected, but nocturnal cough and dyspnea and wheeze is a little bit tricky. But if you look at different settings, if you are working in a medical school, again, your diagnosing asthma in a right way is much more higher than the general pediatrics practice or general practitioner. But when you look at the different typings, this is just, I will be focusing on the persistent troublesome wheeze subgroup. This is a latent analysis. So there is this subgroup with the yellow one. You can see here, it is the much more troublesome one. And these patients have continuous wheezing. And when you look at the age again, when the child is getting older, there is again the chance to diagnose the patient is getting higher. So in conclusion, many cultures do not have a word for wheeze. Nearly half of the parents struggle to identify wheezing sounds. Doctors fear patients will be undertreated due to the unawareness of wheezing. Wait and see approach may cause delayed intervention to prevent attacks, and physicians hesitate they will miss any underlying diagnosis, mainly pneumonia. So take-home message for me, my lecture is, it's important to clarify the sound heard by the parents and even by doctors. We need to standardize it. Artificial intelligence may help us to overcome barriers, and wheeze scan seems to be the first step. Maybe we should be following Omron for the next steps. Thank you for your attention.